Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk. Happy Thursday, everyone. Welcome to Mountain West AETC Echo. Happy to see you all. Hope wherever you are logging in from, you are doing well. The IAS-USA group has released an update to their guidelines, which covers both treatment and pre-exposure prophylaxis. Dr. Steckler is going to review the PrEP portion in a couple of weeks. There are some very notable things there, especially because the CDC PrEP guidelines haven't been updated to incorporate a number of the things that these guidelines have. So stay tuned for the summary of the PrEP guidelines from Joanne in a couple weeks. I'm going to do a summary of the treatment portion. There are many parts that align with the Department of Health and Human Services guidelines. There are a couple places where there are subtle differences. There are a couple places where there are newer things here than the Department of Health and Human Services guidelines have incorporated thus far. So I'm going to highlight that. Some of these things will be review, really just good kind of take-home clinical reminders. And then there are a couple of notable new things and a hint at things to come in the near future. So let's go ahead and get going here. I don't have any disclosures or financial conflicts. This is where you can find the guidelines led by Mike Saig, published in JAMA, updated on October 14th, 2020. I'm going to show you a couple places because I think it is notable the level of evidence listed in the guidelines. And this is just a reminder, basically, A is stronger evidence than B is stronger than C, and 1 better than 2 better than 3. So we'll just go through the various treatment portions. Again, some review here, some good clinical reminders, and then a couple of new and notable things. So first, when to initiate ART. I think you all know that there is great support now for starting as soon as possible. We do not need to wait for genotype results, which we used to routinely do. And these guidelines, like other guidelines, support starting as soon after possible, including immediately after, including same day as diagnosis or first clinic visit, if the patient is ready to commit to treatment. They do call out a recommendation for immediate ART, so that would basically be as soon as possible for individuals with acute or primary HIV. As a reminder, again, I think you know this, but if you are starting before genotype result, you do want to make sure to choose an agent unlikely to be affected by transmitter resistance, and usually our go-to there would be bictegravir with 2 NRTIs or dolutegravir with 2 NRTIs. A boosted PI and 2 NRTIs also very, very reasonable. I'll highlight this because we haven't talked about it in a while, but these guidelines do make note that ART should be initiated within 2 weeks for the vast majority of opportunistic infections. These are the exceptions that they highlight. 1, cryptococcal meningitis. They note a recommendation to start 4 to 6 weeks after starting antifungal therapy. And then for TB, based on a number of clinical trials, if the CD4 count is below 50, these guidelines and others recommend starting ART within 2 weeks. If someone has HIV and TB and a CD4 count above 50, balancing the benefits of early ART versus the risk of IRIS, they come out with this recommendation, which is start 2 to 8 weeks after starting TB therapy. So just slightly later than if somebody has a CD4 count below 50. They make this interesting note, if somebody has a new diagnosis of cancer and is not on ART, that should be a situation to prioritize and more urgently get somebody on ART, acknowledging or taking into consideration drug-drug interactions with ART and upcoming chemotherapy. And that's based on data that individuals with cancer who are receiving treatment have better outcomes if they are taking effective suppressive antiretroviral therapy. So that's an interesting note that I haven't seen in other guidelines. And then I just included this quote because I think it's a great reminder that we have all this emphasis on early, immediate ART, but that's not the only thing that's important for long-term success with care. I liked the way they said this. Robust, culturally sensitive care engagement strategies are required, including attention to essential needs such as housing and food. I think all of you know that, but I thought that was well said, and I was glad they called that out. In terms of initial ART regimens, There is a lot of alignment here with the Department of Health and Human Services, and I'll just note a couple of exceptions. So in alphabetical order here, they emphasize that first regimens should include an integrase inhibitor and 2 NRTIs. They favor bictegravir or dolutegravir. So a difference here is in the HHS guidelines. There is support for raltegravir as a first regimen. These guidelines highlight that given pill burden and lower barrier to resistance, they wouldn't favor raltegravir. They also clearly have removed the boosted elvitegravir option from their recommended list. And that again is due to lower barrier to resistance, drug-drug interactions, tolerability. And I have to say, for first starts of ART, I can't remember the last time I wrote for raltegravir or elvitegravir or abacavir for that matter, just given tolerability and other issues. So favor here bictegravir or dolutegravir. And then what's been added, just like to the Health and Human Service Guidelines, is this option of dolutegravir and 1 NRTI. So dolutegravir 3TC, which is lamivudine. So this is the combo pill that has been studied as initial ART or as a switch in somebody suppressed for maintenance ART. So it's been added to both sets of guidelines as an option for initial ART. I can't say I've written a prescription for it yet. I think we could debate pros and cons of doing this versus a 3-drug TAF-based regimen until somebody's suppressed and then transitioning to 2-drug ART. But it is a reasonable consideration, especially if you have someone who has contraindications to tenofovir-based products and abacavir. There are important caveats, though, and the list here of caveats is similar to in the HHS guidelines. So dolutegravir lamivudine, if you're using it for a treatment-naive individual, is not recommended for rapid or immediate start. They do recommend you have genotype results available. That is to make sure that both agents are active because it is only 2 drugs. I think that point is debatable to some degree. There was a test and treat trial done with dolutegravir lamivudine, and individuals did fine. What they did is they drew all the labs, started dolutegravir lamivudine, and then if somebody had a reason based on genotype or if their Hep B came back positive, then they switched at that point. It was fine. It was safe. People did okay. I just can't clinically think of a reason why I would do that. I really want to know, especially if somebody has Hep B before choosing this regimen. To me, that's priority number 1. I think rates of transmitted integrase resistance and M1A4V and resistance that would affect this regimen are pretty darn low. But for me, that's the bigger thing. I really want to know Hep B status before opting for this. So I largely favor go for a 3-drug regimen, use TAF, get the viral load suppressed, then consider switching to this as maintenance. But just so you know, there is support for this in both guidelines as an initial therapy. Oh, I should say the other caveats here. So definitely would never use this in the setting of chronic Hep B or in the setting of active OI treatment. And then the study that looked at this as initial therapy, which we reviewed before, it was called Gemini, only included individuals with a viral load below 500,000, so would not offer this to anyone with a viral load higher than that. And then in that trial, there was a statistically lower rate of success if individuals had a baseline CD4 below 200. However, numbers were really small. It was only a few individuals who had a CD4 that low. So perhaps would avoid it if CD4 below 200. I think I'd be pretty conservative there and likely avoid it. So those are first-line regimens as recommended by these guidelines. Again, bictegravir or dolutegravir with either TAF-FTC or TDF-FTC or TDF-3TC or the dolutegravir 3TC combination. So again, getting away from the boosters, getting away from the lower barrier resistance drugs, getting away from abacavir. Now, one thing I find interesting about these guidelines is in prior iterations, they had argued much more strongly for starting everyone on TAF as opposed to TDF, and I felt like they backed off from that a little bit here, and I presume, I do not know this for sure, but I presume that's both because of more and more data, which we'll talk about, suggesting higher weight gain with TAF compared to TDF, and also given insurance coverage changes and generic TDF and more and more difficulty obtaining TAF for certain individuals. So just so you know, there is support in these guidelines for using either TAF-based or TDF-based NRTI combinations. So Flipping from just general recommendations for treatment-naive individuals, if you are treating somebody with HIV and tuberculosis using rifamycin-based therapy, these are the recommendations in these guidelines. And I just want to give a reminder that if you're using something like rifampin and TB treatment, you can use dolutegravir, but it should be BID and not daily, or raltegravir at double dose, 800 BID instead of 400 BID, or standard dose efavirenz with 2 NRTIs. TAF and rifampin still in the package insert says do not combine together given potential for lowered TAF levels. These guidelines call out that there was a study in healthy volunteers suggesting that TAF may be okay with rifampin. Levels may not decrease that much, but there's a real absence of clinical experience or clinical data actually treating individuals with HIV and TB with TAF and RIF. So I'd be cautious about that. And then these are the recommended regimens during pregnancy, and I think we have reviewed this at prior sessions. These guidelines, like others, support dolutegravir at any trimester of pregnancy. You can see here the recommended NRTIs, and then we reviewed recently that there is now data for dolutegravir with TAF FTC. That data was only for pregnant women starting that regimen at 14 weeks or later. There's not first trimester TAF data yet, but hopefully we'll see that in the near future. So that's initial regimens. I wanted to just show you the language that this committee came up with for the guidelines on choosing TAF versus TDF and weight gain. So they note that TAF and TDF have similar virologic efficacy. TAF data suggests fewer adverse effects such as proximal tubular toxicity and reductions in bone mineral density, but those differences are most pronounced when TDF is given with a booster with ritonavir or cobicistat. So I think that practically it really comes down to clinical judgment if you're choosing initial therapy for somebody, whether to use TAF or TDF. And I think it really involves judgment about risk to the kidneys, risk to the bones, and then of course insurance coverage. And it is getting tougher to access TAF, and there are situations where we have to argue for TAF if we think someone really needs it. Now, we've discussed that TDF reduces plasma lipid levels. TAF has been associated with more weight gain. However, the clinical significance is unknown. I'll show you a little more language about this on the next slide. And then cost of TDF-containing regimens is likely to decrease as generic formulations become available. So there may be added insurance criteria or requirements for initiating TAF instead of TDF. This is the language on weight gain. Just a couple of notes. We've talked about this. There's going to be more coming in the future, but I do think it's notable how the Guidelines Committee decided to discuss it. So initiation of ART often leads to weight gain, can lead to obesity among individuals with HIV who start treatment with a normal or greater baseline weight. Risk factors, which are consistent in a lot of studies for excess weight gain, include a low pretreatment CD4 count, a high pre-treatment viral load, black race, female sex, dolutegravir and bictegravir more than efavirenz, and TAF more than TDF. However, clinical consequences, long-term outcomes, mechanism remain largely unknown. There is this note that part of the difference or all of the difference between TDF and TAF may be because TDF actually inhibits weight gain, and we're seeing more and more studies, and there even was one just at ID Week, that the difference in weight between TAF and TDF may not be because TAF is inducing weight gain in any way. It may just be because TDF was suppressing appetite and suppressing weight gain or leading to weight loss more than we ever understood. So I don't think we know the clinical consequences of this or implications. I don't think we know the exact mechanism. And this Guidelines Committee decided that it was not strong enough data or understanding yet to sway their advice on initial therapy. But stay tuned for more on that. It's certainly one of the hottest topics in HIV medicine right now. Now, they do have a section on switching or simplifying ART. I just want to highlight a couple things here. And one notable thing, which is they did decide to include advice for long-acting cabotegravir rilpivirine, which is pretty notable. They put that in the guidelines, which makes me think they know something, and this is coming relatively soon. So before switching, I think you all know this, review ART history, tolerability, co-medications, food requirements, cost, and results from all prior resistance tests before switching, and after any switch, follow the viral load closely, including a recheck at 1 month. Now, when switching somebody whose viral load is suppressed, of course, as we've reviewed, make sure the new regimen will effectively treat Hep B if they have Hep B co-infection. Avoid a switch from a boosted PI to a regimen of lower barrier to resistance if there are underlying NRTI resistance mutations or if there are prior virologic failures that raise your concern for underlying NRTI resistance mutations. And then, this era of switching to 2 drugs for somebody whose viral load is suppressed, who's done really well on ART, so-called maintenance therapy, I think is a really interesting era. And I think we have really solid data for switching to dolutegravir rilpivirine, for switching to dolutegravir lamivudine. And then what is likely coming is our first long-acting intramuscular injections of 2-drug maintenance therapy. And these guidelines call out support for long-acting IM cabotegravir rilpivirine given every 4 weeks or every 8 weeks. What has already been approved in Canada is every 4-week dosing. I was intrigued and a little surprised they included support for every 8-week dosing here. The trial that compared every 8-week cabrilpivirine to every 4-week cabrilpivirine did find them to be non-inferior virologically, but with every 8-week dosing, there were more virologic failures, and those virologic failures did have both NRTI and integrase resistance. So what they mentioned here is that if you're going to do every 8-week dosing of this combination, it has to be somebody who really is going to adhere to all of their doses. But once these are approved, we will be reviewing all that data and all that guidance in much more detail. But for now, just know that it is likely coming soon, and there are some words of advice included in these guidelines. Now, switching for virologic failure, again, these are mostly just clinical reminders. Remember that resistance testing is recommended ideally while somebody is taking their failing regimen or within 4 weeks of stopping. I think practically speaking, that often doesn't happen because an individual shows up to clinic with much more time than that off their medications. And in that situation, I think it's a judgment call whether to do the resistance test, wait, or do the resistance test and craft a new regimen and then adjust, or if they were, for example, taking a regimen with a very high barrier resistance and took 100% and then stopped 100% just to restart and follow the viral load. So that involves some, I think, clinical judgment making. If you can get resistance testing on the regimen within 4 weeks, it is more reliable. They define virologic failure as a level above 200 copies, as in other guidelines, and as we've talked about. They do make this note that dolutegravir plus 2 NRTIs is recommended after failure of an NRTI plus 2 NRTIs. We've reviewed the Donning study and that data and support for that, and that BIC or dolutegravir plus 2 NRTIs seems to be effective in the setting of an isolated M1A4V as long as one of those NRTIs is active. And then in the setting of multi-class resistance, the next regimen should use agents from new classes such as fostemsavir, the recently approved attachment inhibitor, or ibalizumab, the post-attachment entry inhibitor, if you will, which is an IV drug about every 2 weeks. I think we've talked about those. I haven't written for fostemsavir yet. I was chatting with Bob Harrington in clinic yesterday. He says he has, and that patient is doing well. But these really are salvage drugs when you have no other options. And then just a couple of final notes so that you know that there is support out there in the setting of cardiovascular disease. These guidelines say if moderate to high risk for a cardiovascular event or if already experienced a cardiovascular event, we should switch off abacavir or PI. They don't really go into what that means, moderate to high risk, so I think that involves clinical judgment. The exception that they make is if someone's taking atazanavir. The reason for that is higher bilirubin levels from atazanavir may actually be cardioprotective because it's an antioxidant, and there's a little bit of data for that. But there's all these other issues with atazanavir, so it still wouldn't be my optimal choice, but less pressing, I suppose, to get someone off atazanavir in the setting of cardiovascular risk. And then they come out and say that if someone has TAF-associated or integrase inhibitor-associated weight gain, there is not enough data yet to say whether they should switch off or not. I agree with that. I think it's pretty clear that individuals taking TAF compared to other NRTIs or an integrase inhibitor compared to other anchor drugs do gain more weight. I think what we do not know yet, again, is the mechanism, the long-term consequences, or whether it's reversible and whether switching to something else helps. There is an ACTG study that is going to start enrolling soon, that is going to enroll individuals with integrase inhibitor-associated weight gain and randomize them to either continue their regimen or switch to doravirine TAF-FTC or switch to doravirine TDF-FTC. And I think that is going to be very, very informative, and we are going to be a site and enrollment hoping to start soon. So stay tuned for more on that. In the meantime, I think it's really, if somebody has gained a lot of weight on one of those agents, one-on-one individualized discussion about pros and cons and other options and risks and benefits of switching therapy. Finally, I'm going to wrap up here in just a moment. Finally, these guidelines also support checking a serum cryptococcal antigen in anyone whose CD4 count is below 100. I think that's just a good clinical reminder. And then baseline genotype testing, they still say do it, and they still say we do not need baseline integrase inhibitor resistance testing. And again, I think that's just a good reminder and support for what we've been doing. And with low-level viremia, it comes up so much. And they clearly say if somebody's viral load is persistently between 50 and 200 copies, we should assess for treatment adherence, tolerability, and toxicity. But changing ART regimens is not recommended unless there's some strong reason to do it. Again, because those viral loads between 50 and 200 tend not to be clinically significant or dangerous to the individual. So that was my whirlwind summary. Hopefully those were good clinical reminders and a couple of novel things and points about things likely to come in the future. I will pause there and look for questions. I see some paragraphs in the chat box that I have not had a chance to look at, but I'll see if there's any hands and questions, and I'll do my best to read in the chat box as well. Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.